Welcome to Section 8 of Genetics. In this section, we'll be discussing autosomal recessive diseases with an emphasis on cystic fibrosis. There are many autosomal recessive diseases, and this is a list of them right here. Notice that unlike the last two videos, we haven't created a picture mnemonic for autosomal recessive disorders. This is because if you've memorized all of the autosomal dominant and X-linked recessive disorders, then you can deduce that any other genetic disease that you see on step 1 must be autosomal recessive. Therefore, in this video, rather than covering every autosomal recessive disease, we'll focus on cystic fibrosis. Cystic fibrosis, or CF, is an autosomal recessive disease caused by cystic fibrosis transmembrane regulator, or CFTR, gene mutations. More specifically, it's usually due to a 3 base pair deletion of the 508th amino acid position affecting the amino acid phenylalanine. So deletion of phenylalanine at the 508th position. CFTR is an ATP-gated chloride channel that normally secretes chloride in the GI tract and lungs and reabsorbs chloride in the sweat glands. Let's pull up an image so you can see what I'm talking about. This is a figure of the CFTR channel in both healthy individuals and individuals with cystic fibrosis. This can be found in Section 8 of Genetics. So the epithelial cells in the lungs and the GI tract are represented by the epithelial cells on the left side of the image right here. In normal individuals, the CFTR channel is responsible for secreting chloride from the cytosol to the extracellular space. You can see that right here. Also notice that there are transporter proteins for sodium and water that go in the opposite direction. Normally in the lungs and the GI tract, there is some thin mucus that bathes and protects the epithelial surfaces. You can see that right here. Because chloride acts as an osmotic agent, it pulls water into the mucus and results in mucus thinning. So notice that chloride is seen in the mucus and it pulls water inside of it. In patients with CF, so CF epithelial cells, the CFTR channel is defective, which means chloride cannot leave the cell. This results in cytosolic chloride retention, which you can see right here. Notice that the osmotic force of chloride causes excess sodium and water to enter the cell. This is represented by these very large arrows right here. Ultimately, the mucus contains less water, resulting in a thick and viscous mucus, which you can see right here. In sweat glands, the CFTR channel works in the opposite direction. Notice that chloride is shown being reabsorbed by the cell, right here. Also notice that sodium follows chloride through its own channel. In individuals with cystic fibrosis, the chloride cannot be properly reabsorbed by the cell, and you can see that right here in the sweat gland. Notice that this results in an extracellular increase in both sodium and chloride. In other words, the sweat of these individuals becomes more salty. This is actually one of the ways CF can be diagnosed, which we'll talk more about later. So in summary, remember that cystic fibrosis results in thick mucus and salty sweat. Okay, continuing along, when the CFTR protein contains a mutation, this typically results in impaired glycosylation and proper folding of the protein. We covered this idea in cell biology, but recall that when proteins are not folded properly, they're tagged by ubiquitin and then sent to the proteasome for degradation. The clinical features should be very intuitive if you understand the basic pathophysiology, so hopefully you don't have to memorize all of this information. Again, the basic pathophysiology all revolves around the idea of thick mucus. Thick mucus in the lungs results in impaired mucociliary function. The stasis of thick mucus predisposes the lungs to colonization by bacteria, resulting in recurrent sinopulmonary infections. Two common microorganisms that cause these infections are Pseudomonas and Staph aureus. The thick mucus, along with the recurrent infections, also irritates the lungs and causes inflammation of the bronchi or bronchitis. Over time, this can cause bronchiectasis, which is permanent damage and dilation of the bronchi. Eventually, this can lead to respiratory failure, chronic hypoxia, and digital clubbing. In men, the vas deferens is blocked or absent, resulting in azoospermia and infertility. The etiology here isn't completely understood, but in my mind, this makes sense because I think of thick mucus obstructing the vas deferens during embryogenesis, resulting in a blocked or absent vas deferens. Therefore, these patients make sperm, they just can't transport sperm to the urethra. This means that they can actually have children if they use assisted techniques. In women, the thick cervical mucus prevents sperm from penetrating into the uterus, which also results in infertility. The thick mucus in the sinuses causes inflammation in the nose and sinuses, resulting in nasal polyps. The thick mucus in the pancreas causes pancreatic obstruction and inflammation, eventually leading to pancreatic insufficiency. Over time, the pancreas develops cysts and fibrotic tissue, which is actually how the disease got its name. Exocrine pancreatic failure leads to fat malabsorption, leading to vitamin A, D, E, and K deficiencies, and endocrine pancreatic failure can lead to diabetes. In newborns, the first stool is known as the meconium. The thick mucus in the GI tract can cause a very hard or thick stool, which can cause an obstruction. This is called a meconium ileus. Finally, stasis and thickening of the bile can cause biliary disease, which leads to recurrent obstruction and inflammation. Eventually, the obstructed bile ductules can cause cirrhosis, or liver disease. A diagnosis can be made by detecting elevated chloride concentrations in the sweat. This idea should be pretty intuitive to you if you understand the pathophysiology. So again, if we pull up the overview figure, we can see that the CFTR protein normally reabsorbs chloride in the sweat glands. You can see that right here. If the protein is not functioning, then chloride cannot be reabsorbed. This means there will be excess chloride secreted in the sweat. Sodium follows the chloride, resulting in an increased sodium concentration. So there will be increased sodium chloride in the sweat. Alternatively, a diagnosis can be established with molecular testing or by detecting a negative transepithelial potential difference. This idea is getting at the fact that CF patients have a more negative voltage due to abnormal sodium processing. An alternative screening test is immunoreactive trypsinogen. Recall that trypsinogen is an inactive pancreatic zymogen that becomes activated when it reaches the intestines. In CF patients, the thick pancreatic mucus secretions prevent trypsinogen from reaching the small intestine, which can cause it to be partially absorbed in the blood. Immunoreactive trypsinogen is a type of trypsinogen that becomes elevated in the blood when the pancreas is plugged. If it's elevated in a newborn, it can be used as a screening tool for cystic fibrosis. The exact treatment of cystic fibrosis is beyond the scope of step 1, but you should know that these patients are treated by a multidisciplinary team, which involves many factors such as chest therapy, antibiotics, pancreatic enzymes, and potentially even lung transplants. 2 drugs that are worth knowing are lumacaftor and ivacaftor. These are drugs that correct the misfolded CFTR protein and enhance the protein function once it reaches the plasma membrane. Okay, let's do a question. How can infertility in men with cystic fibrosis be distinguished from infertility in men with Cartaginer syndrome? As we just learned, in cystic fibrosis, the vas deferens is blocked or absent, resulting in azoospermia and infertility. In Cartaginer syndrome, the sperm lacks cilia, so they're unable to reach the oocyte. I talk more about Cartaginer syndrome in the chapter on cellular biology, so go check that out if you're not familiar with Cartaginer syndrome. Because both diseases are genetic conditions that result in respiratory problems, they're often tested together. So be sure to understand the differences between these 2 conditions. Okay, let's do another question. A 21-year-old Russian male presents to the physician with a fever, productive cough, and chest pain. He states that for most of his life, he has lived in a rural area in Russia, but believes he has had multiple similar episodes that were undiagnosed. He also endorses fatty stools. On exam, he has peripheral neuropathy. A chest x-ray is consistent with lobar pneumonia. Which of the following is most likely true of this patient's condition? A. Methylmalonic acid levels will be increased. B. The condition will result in increased ubiquitin tagging of an abnormal protein. C. The condition will improve if he eats more green vegetables. Or D. The condition is associated with HLA-DQ2 and HLA-DQ8. From the question stem, hopefully you notice that this patient has a history of recurrent pneumonia. He also has fatty stools and peripheral neuropathy. These findings should make you think of cystic fibrosis. The fatty stools can be explained by pancreatic insufficiency, resulting in fat malabsorption. This can cause fat-soluble vitamin deficiencies, including vitamins A, D, E, and K. Vitamin E deficiency can cause neuropathy, which is what this patient has. So cystic fibrosis results in pancreatic insufficiency, causing fat malabsorption, vitamin E deficiency, and neuropathy. With this in mind, we're asked what is most likely true of this patient's condition. The correct answer is B. The condition will result in increased ubiquitin tagging of an abnormal protein. Recall from the pathophysiology of cystic fibrosis that the CFTR protein contains a mutation resulting in impaired glycosylation and proper folding of the protein. When proteins are not folded properly, they're tagged by ubiquitin and then sent to the proteasome for degradation. A is alluding to a vitamin B12 deficiency, which can cause peripheral neuropathy, but this doesn't explain his respiratory symptoms or fat malabsorption. C is alluding to a folate deficiency, which can cause neurological symptoms, but again, doesn't explain his respiratory symptoms or fat malabsorption. D is alluding to celiac disease, which can cause fat malabsorption, but doesn't explain his respiratory symptoms. So again, the correct answer is B.